Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic, that is disorders of the aorta, in which I will be discussing the very important topic, that is aortic dissection. So, if you see the definition of the aortic dissection, it is the dissection of blood between and along the laminar planes of the aortic media. So if you take an arterial wall, it has three layers. Innermost layer will be the tunica intima, then we have tunica media, and the outermost layer will be tunica adventitia. So in aortic dissection, what will happen is there will be dissection of blood between there will be dissection of blood between and along laminar planes of tunica media or the aortic media. Okay, so that is about what is called as the aortic dissection. And this aortic dissection, let me tell you, it is one of the catastrophic illness. Right, it is one of the catastrophic illness which is characterized by, now why it is considered as this catastrophic illness? Because you can observe that here there will be a creation of the false lumen. Right, you can observe that here. Once the blood seeps into the tunica media, there will be creation of a false lumen. Right, and this particular false lumen, it can rupture. Right, once it ruptures, the blood gets dissipated into the various cavities. Okay, so in these individuals there will be an intimal tear. So how do you think that the blood will enter into the tunica media? Blood enters the tunica media at this intimal tear, and the blood dissects between dissects between the layers of dissects between the layers of smooth muscle in the tunica media. So that is what will happen in patients with the aortic dissection. So I said you that there will be creation of a false lumen. Right, there will be creation of a false lumen containing the blood-filled channels, and this blood-filled channels, they get ruptured. Right, they get ruptured outwards, causing the massive hemorrhage. Right, causing the massive hemorrhage. Okay, now this particular massive hemorrhage, it could be into the pericardial space. Resulting in pericardial effusion, or that particular massive hemorrhage, it could be into the pleural space, resulting in the pleural effusion. Right, so this is the little basic introduction of what exactly happens in aortic dissection and why is it very much catastrophic. Now you need to know what are the risk factors for the development of aortic dissection. Aortic dissection is associated with systemic hypertension, coarctation of aorta, first trimester of pregnancy, Takayasu arthritis, Marfan syndrome. Let me tell you, you have many predisposing factors, right? I'll discuss all the predisposing factors and then I'll come back to this question once again. So, if you take the predisposing factors, let me tell you, the major factor that contributes to the development of aortic dissection is arterial hypertension, right? So, arterial hypertension right, it is a major risk factor, and this arterial hypertension, it constitutes 80% of patients developing aortic dissection, right? In almost 80% of patients, it is the arterial hypertension which will be responsible for the development of aortic dissection. And in these individuals with aortic dissection, when you observe the blood pressure or when you measure the blood pressure between the two arms, there will be asymmetric blood pressure, right? Asymmetric blood pressure and asymmetric pulses between the arms, right? Asymmetric pulses between the arms. So, now what are the other predisposing factors? One of the very important predisposing factors is systemic hypertension. The other predisposing factors include cystic medial necrosis, right? Second, Marfan syndrome. Then followed by that, Ehlers-Danlos syndrome. Now, let me discuss, few points related to this Ehlers-Danlos syndrome. So, Ehlers-Danlos syndrome, it is a hereditary connective tissue disorder. Right, it is a hereditary connective tissue disorder. And what is the type of inheritance? Let me tell you, we have many variants of the Ehlers-Danlos syndrome, and the type of inheritance is either autosomal dominant or autosomal recessive. Now, what are those variants and all, we will discuss. And what will be the important clinical features of this Ehlers-Danlos syndrome, right? The signs and symptoms in Ehlers-Danlos syndrome include joint hypermobility, right? Number 2, skin hypermobility. Number 3, tissue fragility. And the development of pain. So these are the clinical features of the Ehlers-Danlos syndrome. Now, so I said you, it is the defect in the connective tissue, right? It's a connective tissue disorder, and it is basically a disorder within the collagen. Now, what is that collagen which is being affected is, it is type 3 collagen which is being defective. Now, I said you, like, we have various variants of the Ehlers-Danlos syndrome. What are those? These are all the various types. We have classical type of Ehlers-Danlos syndrome, hypermobility type of Ehlers-Danlos syndrome, vascular type of the Ehlers-Danlos syndrome, then we have kyphoscoliotic type of Ehlers-Danlos syndrome, arthrochalasia type of Ehlers-Danlos syndrome, dermatosparaxis type of the Ehlers-Danlos syndrome. Now, out of all these, what is that we are very much interested in the aortic dissection is the vascular type. if you take vascular type of Ehlers-Danlos syndrome, that is the one where the individual has the development of the aortic dissection. Okay, and this is autosomal dominant type of inheritance. I said you Ehlers-Danlos, it is either autosomal dominant or autosomal recessive. Now, which particular subtype it is of autosomal recessive? If you take the kyphoscoliotic type, this is autosomal recessive type of inheritance. Then you take dermatospraxis type, even this is also an autosomal recessive type of inheritance. And if you take the other types, they are all autosomal dominant type of inheritance. So, if you take this vascular type, the collagen which is being defective is type 3 collagen, and the gene which is abnormal, right? The genetic abnormality is in col3A1, right? col3A1. That is the genetic abnormality that you will have in vascular type of the Ehlers-Danlos syndrome, resulting in the aortic dissection. Okay, so to summarize, if you take the vascular form of aortic dissection of Ehlers-Danlos syndrome, right, number one, the type of inheritance is autosomal dominant type of inheritance, right? And this vascular form, sometimes it is referred as type 4. Right, sometimes it is referred as type 4 Ehlers-Danlos syndrome. And what exactly will happen here? There will be decreased amount of type 3 collagen. Right, there will be decreased amount of the type 3 collagen. Right, and there is also mutation in a particular gene. So the gene which is being mutated is col3A1. Right, the gene which is being mutated is col3A1. This is the gene which is being mutated, resulting in the vascular form of the aortic dissection. Right, so these are the predisposing factors. Most common predisposing factor is systemic hypertension, and other predisposing factors are Marfan syndrome and then the Ehlers-Danlos syndrome. Apart from that, we also have the inflammatory aortitis, which will predispose to the development of the aortic dissection. Now, what are those inflammatory aortitis? Like, for example, you take large vessel vasculitis, that is Takayasu arthritis. Right? Number 2, giant cell arthritis. Right, number 2, giant cell arthritis. So these two are your inflammatory aortitis which can cause the aortic dissection, right? And then coarctation of aorta. Right, next, normal women during 3rd trimester of pregnancy. Right, normal women during third trimester of pregnancy. Okay, and congenital aortic valve anomalies like bicuspid aortic valve. Right, bicuspid aortic valve. So these are all the predisposing factors for the development of the aortic dissection. So going back to the question now, aortic dissection is associated with systemic hypertension, coarctation of aorta, first trimester of pregnancy, Takayasu arthritis, Marfan syndrome. So except your first trimester of pregnancy, all others, they are associated with the development of the aortic dissection. Now, what are the manifestations of aortic dissection? Manifestations of aortic dissection are all except pericardial effusion, aortic regurgitation, mitral regurgitation, acute myocardial infarction, limb ischemia. Now let me tell you the clinical course, right? The clinical course of the aortic dissection completely depends upon the level of the aorta which is affected. Okay, so the risk and nature of serious complications of dissection depends strongly on the level of the aorta affected. Right? It strongly depends on the level of the aorta defected. And which part of the aorta, if it is affected, the individual will have serious complications? That is, the individual will have serious complications occurring from the aortic valve to the aortic arch. Okay, so if the dissection is from the aortic valve up to the level of the aortic arch, if the dissection is at this place, then the individual is predisposed to serious complications. Why? Because from the ascending aorta, there is origination of the coronary arteries. And if the dissection occurs at that level, the dissection can go into the coronary arteries where the individual can develop acute myocardial infarction. And you take the arch of aorta, right? If the dissection occurs at the arch, the dissection can progress into the carotid artery. The dissection can progress into the subclavian artery. The dissection can progress into the right subclavian, right brachiocephalic trunk. Then accordingly, the individual will have the manifestations within the upper limbs, or the individual can have manifestations within the brain. Right? Now depending upon the severity, depending upon the duration. So, the tear in the aortic intima allowing the blood to dissect into the media, if it is there for less than 2 weeks, then it is considered as the acute aortic dissection. And if the blood is dissected into the media and if it is present for more than 2 weeks, then it is chronic aortic dissection. Now, depending upon the site of the aorta where the dissection is, the aortic dissections are generally classified into 2 types. Okay, if you take the classification according to Stanford, we have only 2 types, that is type A and as well as type B. We have another classification, that is Debacke classification. Under the Debacke, we have type 1, type 2, type 3A and type 3B. Now first let me discuss about the Stanford classification. See, Stanford classification, that is type A, this involves ascending aorta plus or minus the involvement of the aortic arch. Right, ascending aorta plus or minus involvement of the aortic arch. And these patients with type A dissection, they require an emergency surgery. Right, they require an emergency surgery. And this type A aortic dissection, this is the most common form. Right, it is the most common form and it is more potentially dangerous. Right, it is more potentially dangerous. That is about your type A aortic dissection. See, when it is involving the ascending aorta and as well as the aortic arch, there can be dissection into the coronary arteries, there can be dissection into the right brachiocephalic trunk, there can be dissection into the common carotid artery, there can be dissection into the left subclavian artery. So the vital organs, they get affected. So that is the reason why this requires an emergency surgery. Whereas distal lesions, they do not involve the ascending aorta. right? They do not involve the ascending aorta. And this is usually benign form, right? And this distal dissection or type B dissection, it is present distal to the left subclavian artery. Right, it is present distal to the left subclavian artery. So let me show you that. So this is your type A dissection where there is involvement of ascending aorta and as well as the arch. Whereas type B dissection is that which involves distal to left subclavian artery. Right, which involves distal to the left subclavian artery. Now, after having discussed about the Stanford classification, let me tell you about the Debacke classification. See, in Debacke type 1, it involves ascending and as well as descending aorta. Right, it involves both ascending and as well as it involves both ascending aorta and as well as the descending aorta. Whereas type 2, there is involvement of the ascending aorta only. Right, involvement of ascending aorta only. And this particular dissection which is involving the ascending aorta, it stops at the innominate artery. Right, it stops at the innominate artery. Then you take 3A. 3A is that which involves descending aorta only. Right, descending thoracic aorta only. That means in case of type 3A, the dissection is present distal to the left subclavian artery and proximal to the diaphragm. So it is present distal to left subclavian artery and proximal to diaphragm. Okay, that is what will happen in type 3A. Whereas type 3B is, it is 3A plus involvement of the abdominal aorta. Right, type 3A plus involvement of the abdominal aorta. So that is your Debacke classification. So type 1, involvement of ascending and descending aorta. Type 2, involvement of only ascending aorta and it stops at the innominate artery. And I'll just show you that. Yes, you take type 1. So in type 1, there is involvement of both ascending and as well as the descending aorta. Whereas in type 2, involvement of only ascending aorta and it stops at the innominate artery, which is nothing but your right brachiocephalic trunk. Whereas type 3A, it involves distal to the left subclavian artery but proximal to the diaphragm. Whereas 3B, it involves both the descending thoracic aorta and as well as the abdominal aorta. That will be your type 3B. So this is about the Stanford classification and as well as the Debacke classification. Now, after having discussed about the classifications, let me discuss what exactly will be the clinical features in these patients with the aortic dissection. So the individual has sudden excruciating pain, presumably attributable to the progress of the medial cleavage. So the individual will have very severe pain, and this particular very severe pain, it announces the onset of dissection in 90% of instances. That means at the onset of pain, the pain will be very severe. Right? At the onset, the pain will be very severe. And what will be the character of this particular pain? It is cutting type of pain, right? Or it is ripping type of pain, or it is tearing type of pain. That will be the character of pain in aortic dissection. And where exactly is the site of pain in aortic dissection? Patients will most commonly locate the pain or discomfort to the anterior chest. Right, we'll locate this pain to anterior chest. Okay, and from the anterior chest, the pain will radiate to the interscapular area. Right, will radiate to the interscapular area. And not only that, the pain will also progress to the epigastrium, right, or the pain will also progress to the lumbar region. Okay, so these are the site of pain and their progression or radiation. Now, there are two features of the pain of dissection that helps to separate it from the other condition. What is that? Number one, the discomfort of dissection typically is at its most intense from its inception. Okay, so the pain is severe at the onset. Right, the pain is very severe at the onset. Okay, and second important point is it is often located either simultaneously or sequentially in more than one of four sites. Okay, so it is present, the pain is present simultaneously at one of the four sites. Right, the pain is present at more than, right, more than one of the four sites. Okay, what are those four sites? Anterior chest, interscapular area, epigastrium, lumbar region. So in more than one area the pain will be there. Now, what are the other common clinical features? You need to know the most common cause of death in patients with aortic dissection is rupture of dissection outwards into any of the three body cavities. So, most common cause of death will be rupture of dissection into any of the three body cavities. Right? And what are those three body cavities? Either into the pericardial cavity, right, or into the pleural cavity, right, or into the peritoneal cavity. So the rupture of the dissection will be into any of these three body cavities. And let me tell you, this particular dissection can progress in a retrograde fashion also. right? Retrograde dissection into the aorta can make the individual to develop aortic regurgitation, right? Retrograde dissection into the aorta or into the aortic root can cause the aortic regurgitation. Thus, the common clinical features are, right, the common clinical manifestations are, number one, aortic regurgitation, or this, it can rupture into the pericardial cavity resulting in the cardiac tamponade. And if the dissection progresses into the coronary artery, the individual will develop myocardial infarction, right? And if the dissection progresses into the spinal arteries, there can be development of transverse myelitis, right? Transverse myelitis, if the dissection progress into the spinal arteries. Right, if the dissection progresses into the spinal arteries, then there can be development of transverse myelitis, right? And the dissection, it can also progress into the great arteries of the neck, right? The dissection can also progress to great arteries of the neck, or it can also progress to the renal arteries, right? Or it can also progress to renal artery, right? Or it can also progress to iliac arteries. Okay, so these are the sites where the dissection can progress into. Now, so these are all the clinical manifestations. Very important is the chest pain, and all other manifestations are secondary to the complications of the aortic dissection. Next, on examination, what is that you will observe, right? See, there can be asymmetrical blood pressure and asymmetrical pulses. That already I have discussed in the beginning of the session itself. But you take the murmurs of aortic dissection. Murmurs of aortic dissection, it can be heard in about half of all patients with acute type 1 dissection. So, this murmur of aortic regurgitation you will see in half of all patients with acute type 1 dissection, right? And why does this aortic regurgitation occurs? It occurs due to retrograde dissection into the aortic root. Right, it occurs due to retrograde dissection into the aortic root. So this is about, and what will be that murmur of aortic regurgitation? That will be early diastolic murmur, right? So this is about the clinical features and examination findings in patients with the aortic dissection. Then followed by that, let me discuss the investigations in patients with the aortic dissection. So after having discussed about the physical examination, let me discuss the investigations in patients with the aortic dissection. So you take this clinical scenario, 46-year-old man develops sudden severe central chest pain after lifting heavy cases while moving the house. The pain radiates to the back and both shoulders, but not to either arm. His blood pressure is 155 by 90 millimeters of mercury and pulse rate is 92 beats per minute and the ECG is normal. He is distressed and sweaty but not nauseated. what would be the best way to diagnose this clinical condition? So you see the description of the chest pain. It is a central chest pain, right, which is aggravated on lifting the heavy cases, and the pain is exactly radiating to the back in between both the shoulders. Okay, that is in between both the scapula, right? So this is a classical description of the pain of the aortic dissection. And the blood pressure of the individual is also 155/90. See, this is one of the most important predisposing factor for the development of the aortic dissection. So this is a case of this is a case of the aortic dissection. Okay, now what is the way to diagnose aortic dissection? Chest X-ray, transthoracic echocardiography, transesophageal echocardiography, MRI of the aorta, coronary angiogram. Let me tell you, you can do all these investigations in patients with aortic dissection. But what will be the investigation of choice? Investigation of choice will be MRI of the aorta, right? So the most likely diagnosis is aortic dissection, and in this patients of aortic dissection, what are all the various other investigations? Very important is the chest X-ray, right? Chest X-ray, you can make out that one of the differential diagnosis of the case is as aortic dissection. What will be the chest X-ray finding? Number one, first and foremost, very important point, there will be widening of mediastinum. Right, widening of mediastinum, that is one of the very important point. Then followed by that, these individuals will also have the presence of the pleural effusion, and that too which sided pleural effusion? Left pleural effusion. Right, there will be presence of the left pleural effusion, that is due to extravasation of the blood. Now this will be the chest X-ray findings in patients with the aortic dissection. Now followed by that, the other important investigations are MRI and as well as the CT scan. So MRI, it is an excellent imaging modality for chronic dissections. Right, excellent imaging modalities for excellent imaging modalities for chronic dissection. But you take in case of acute conditions, right, but you take in case of the acute conditions. In case of acute situations, the MRI, it takes longer imaging time, and there is also difficulty of monitoring the patient in MRI scanner. And that is the reason why in acute conditions, CT scan, it is preferred. Right, CT scan of the aorta is preferred. Right, and whenever you are taking the CT scan, it should include both the chest and as well as the abdomen. Now, why is that you have to take the CT scan of both the chest and as well as the abdomen? That is because the dissection can be at the level of the thoracic aorta, or the dissection can be at the level of the abdominal aorta. So the CT scan should include both the chest and as well as abdomen. Okay, and that will fully delineate the extent of the dissected aorta. Right, so that is about the imaging modality, that is MRI and as well as the CT scan. Now this is one of the MRI scan of the image showing the aortic dissection. So you can see that here. So this is the dissected aorta, and here you can observe the presence of the false lumen containing the blood. Okay, so this is about an MRI of the chest showing an aortic dissection. So coming to the transesophageal echocardiography. Transesophageal echocardiography, this is also an excellent diagnostic imaging method. And with the help of transesophageal echocardiography, you can visualize only the thoracic part of the aorta. Right, you can visualize only the thoracic part of the aorta. The abdominal aorta cannot be made out by your transesophageal echocardiography, right? So that is about the TEE. And the next important investigation is the ECG, right? Now in the ECG, what is that you will observe is left ventricular hypertrophy. Left ventricular hypertrophy, it can be made out from long-standing hypertension. What did I tell you? The most common predisposing factor for the development of aortic dissection is the hypertension. So if you do an ECG, you will have the features suggestive of the hypertension. Okay, and what will be the features of hypertension in the ECG? So if you take the dimensions, that is SV1 plus RV6, it should be more than 35 mm. Right? SV1 means what? The depth of S wave in lead V1 and the amplitude of R wave in V6, that should be more than 35 mm. Okay, and if that criteria is met, that is suggestive of the hypertension. Okay, next, the another important ECG finding is the acute changes suggesting myocardial ischemia do not develop until the dissection involves the coronary artery ostium. So, if there is dissection of the coronary artery, that is only the point when the ECG will show you the features of the ischemia. So, please remember, until the coronary artery ostium is not affected, the ECG changes of myocardial ischemia do not develop. And the next important point is inferior wall abnormalities, they are seen most commonly. Why? Because the dissection, it leads to compromise of the right rather than the left coronary artery. Okay, so inferior wall abnormalities. Right, inferior wall abnormalities, they usually predominate. Okay, and why is that? That is because right coronary artery involvement is more common than compared to that of the left coronary artery involvement. And in some patients, the ECG may be completely normal also. So that is about the importance of ECG in case of aortic dissection, only to make out whether there is presence of the LVH is there or not to see, and to look for if there is the dissection progressing into the coronary artery. Then the another important investigation is the cardiac biomarkers. So you have to do cardiac biomarkers like troponin I. So troponin I is being done mainly to rule out myocardial infarction. Right, to rule out myocardial infarction. So that is about the cardiac biomarkers. Right, next. Now you see this question. Manifestation of the aortic dissection are pericardial effusion, aortic regurgitation, mitral regurgitation, acute myocardial ischemia, limb ischemia. Let me tell you, pericardial effusion can be there. That is because of the rupture. Aortic regurgitation also can be there. That is due to retrograde movement of the dissection. So due to backward progression of the dissection, there can be aortic regurgitation also, and you will also have the murmur of aortic regurgitation. And if the dissection progresses into the coronary artery, there can be also development of acute myocardial infarction. And if the dissection progresses from the abdominal aorta to the vessels of the lower limb, then the lower limb ischemia or upper limb ischemia can also be there, depending upon to which vessel the dissection have been progressed. But mitral regurgitation, it is not the manifestation of the aortic dissection. Now, after having discussed about the investigations, so what will be the investigation of choice in a stable case? That is MRI of the aorta. And in case of acute scenarios, you cannot do MRI of the aorta, you have to do CT scan of the aorta, both the chest and as well as the abdomen. Now you see the treatment of the aortic dissection. In aortic dissection, the drug used are propranolol, diazoxide, sodium nitroprusside, hydralazine, labetalol. So, in the medical management, first and foremost, very important is you need to control the blood pressure of the individual, because controlling of the blood pressure is important, and at the same time you also need to reduce the heart rate as well. Both of these are the targets in case of the aortic dissection. One, the blood pressure has to be reduced. Second, the heart rate has to be reduced. Now, for that, you need to give a drug which is both an alpha and beta blocker. Then, first of all, why is that you have to reduce the blood pressure and as well as the heart rate of the individual? See, when the cardiac output or the heart rate is reduced, and at the same time when the blood pressure is reduced, the progression of the dissection will be halted. Right? The progression of the dissection will be halted. That is the advantage of reducing the blood pressure and as well as the heart rate. And for that, you need to give labetalol. Right? Labetalol, it is both alpha plus beta blocker. Right? Labetalol, it is both alpha plus beta blocker. Okay? And this will lower, right? This labetalol will reduce the blood pressure and as well as the heart rate. And what is the dosage and all, we will discuss. And I will show you one more clinical scenario. A 60-year-old man presents to the accident and emergency department with a 3-day history of increasingly severe chest pain. The patient describes the pain as a sharp, tearing pain starting in the center of his chest and radiating straight through his back between the shoulder blades. The patient looks in pain, but there is no pallor. Heart rate is 95 per minute. Respiratory rate is 20 per minute. Temperature is 37 degrees centigrade. Blood pressure is 155 by 95 millimeters of mercury. Drug of choice for this clinical condition is esmolol, prazosin, hydralazine, sodium nitroprusside, and then diazoxide. The answer in this question is the esmolol. So, why we need to give esmolol? Everything I will discuss in detail. Okay. So, let me discuss the medical management in detail, and why is that we need to give esmolol also I will discuss in this discussion. So, what is our goal? Aggressive measures have to be taken to lower the blood pressure and as well as the heart rate of the individual. And for that, how much should be the target blood pressure? The target blood pressure should be 100 to 120 millimeters of mercury. That will hamper the progression of the aortic dissection. And for this, the drug already I have said you, what is that you have to give? You have to give labetalol. Why? Because labetalol, it will reduce the blood pressure and as well as the heart rate also. And what is the dosage of labetalol? Labetalol, it is given as a dosage of 20 milligrams and it has to be given over 2 minutes. And the route of administration is the intravenous route of administration. And apart from this 20 milligrams, you also need to give additional doses, right? And what will be that additional doses? Right, the additional doses include 40 to 80 milligrams intravenously. And this 40 to 80 milligrams, it can be given every 10 minutes. Right, this has to be given every 10 minutes. And maximum, how much is the dose? Maximum dose of labetalol is 300 milligrams, right? And you have to give this until the desired blood pressure has been reached, right? So this is about the dosage of labetalol. See, alternatively, 2 milligrams per minute may be given by intravenous infusion titrated to desired effect. So you are giving 40 to 80 milligrams intravenously. But what should be that infusion? right? And this particular infusion or maximum 300 milligrams whenever you are giving, you have to give it at a rate of 2 milligrams per minute, right? 2 milligrams per minute, and you have to repeat these doses up to maximum 300 milligrams every 10 minutes. You can repeat the doses, but what should be your target blood pressure? 100 to 120 millimeters of mercury. Then what is the advantage of this esmolol? See, I'll tell you, esmolol is also a beta blocker, right? So this is a short acting beta blocker, right? Esmolol, it is a short acting beta blocker. See, in patients who have asthma, bradycardia or other conditions that necessitates the patient's reaction to beta blocker to be tested, and esmolol is a reasonable choice in those individuals. Why esmolol is a reasonable choice in individuals with asthma or bradycardia? First of all, it is a selective beta blocker and it's a short acting beta blocker. It has a short half-life, right? It has a short half-life. So because it is having a short half-life, it will reduce the heart rate and as well as the blood pressure for a shorter period of time. So that is the reason why esmolol can be given even though the individual is suffering with an underlying asthma. And what should be the loading dose? The loading dose of this particular esmolol is 0.5 milligram per kg should be given, and this has to be given intravenously, right? And it has to be given over 1 minute. Okay, so that is about the dosage of the esmolol. And you need to titrate the infusion with a goal of heart rate, right? With a goal of heart rate of around 60 to 70 beats per minute. Right, with a goal of heart rate around 60 to 70 beats per minute. So this is about the esmolol. Then the next important group of drugs are the calcium channel antagonists. See, the calcium channel antagonist that can be given as an alternative is the diltiazem and verapamil. Right, that includes diltiazem and verapamil. See, these are the potential alternatives to treatment with beta blocking drugs, right? And these drugs have to be given only when the beta blockers are absolutely contraindicated. That is the point when the calcium channel blockers like diltiazem and verapamil can be given. And what is the role of the morphine sulfate in patients with the aortic dissection? Morphine sulfate is the appropriate drug to use for pain relief. Right. So morphine sulfate is the appropriate drug to use for pain relief. That is about your morphine sulfate. Then next question is, can you give diazoxide and as well as hydralazine? See, diazoxide and as well as hydralazine, both of them, they are direct acting vasodilators. Right, they are direct acting vasodilators. And these are absolutely contraindicated. They should not be given. Why? I will tell you. See, these are absolutely contraindicated because these agents can increase the hydraulic shear and may propagate the dissection. Right, so they can increase the hydraulic shear and propagate the dissection. right, may propagate the dissection. So that is about your diazoxide and as well as the hydralazine. They are not given in case of the aortic dissection. So after having discussed about the medical management, let me discuss about the surgical interventions in the aortic dissection. So according to the Stanford classification, we have type A and as well as type B dissection. Okay. So in case of type A dissection, urgent surgical intervention is required. Okay. So in case of type A dissection, urgent surgical intervention is required. Okay, that is in case of type A dissection. And what does this procedure involve? The procedure involves grafting and replacing the diseased portion of the arch. Okay, so in this patient, what is the procedure involved? Grafting and replacing the diseased portion of the arch. And not only grafting and replacing the diseased portion of the arch, you also have to do the grafting and replacement of the brachiocephalic vessels if necessary. Right, brachiocephalic vessels if necessary. So that is about the treatment for the type A dissection. And you take the aortic valve. In certain scenarios, I have discussed that the aortic dissection can progress retrogradely, where there can be involvement of the aortic valve also resulting in aortic regurgitation. So, replacement of the aortic valve may be required with the reattachment of the coronary arteries. Okay, replacement of the aortic valve right, replacement of the aortic valve, they may be required with reattachment of the coronary artery. So that is about the surgical intervention. So please remember, in all type A dissections, they require urgent surgical intervention. Whereas you take in case of type B dissections. See, in case of type B dissections, like we have two types. Type B dissection with malperfusion, type B dissection without malperfusion. So you take type B dissection with malperfusion first. With malperfusion, these patients, they require urgent surgery. Urgent surgery is required for type B dissection if there is aortic branch compromise resulting in malperfusion of the renal, visceral or extremity vessels. So these patients, they require urgent surgical interventions is required in those individuals where there is malperfusion. Right, so either there is malperfusion of kidney or the malperfusion of visceral organs or the extremity vessels. And what is the immediate goal? The immediate goal of the surgical therapy is to restore the flow to the ischemic tissue. Right, so what should be the immediate goal? Right, the immediate goal is to restore the blood flow to ischemic tissue. Right, that should be the immediate goal. Right, and these patients, with malperfusion, any of the visceral organs, they may get affected. And that is the reason why urgent surgical therapy is required. Whereas, you take in type B dissection without malperfusion. Type B dissection without malperfusion, these patients, the blood pressure control is the primary treatment. Right? The blood pressure control is the primary treatment, and long-term aortic specific survival and late aneurysm formation rates are improved with early thoracic stent graft repair. So, in order to prevent the long-term complications, in these patients, what you can do is, you can do an early thoracic stent graft repair. Right, an early thoracic stent graft repair has to be done in order to prevent the late complications like aneurysm formation. And particularly you have to do this aortic stent or thoracic stent graft repair in scenarios where the aortic diameter greater than 4 centimeters or where there is partial false lumen thrombosis. Okay, so this has to be done in individuals where aortic diameter more than 4 centimeters or where there is partial false lumen thrombosis. So in that case, you need to do an early thoracic stent graft repair. So this is about type B dissection without malperfusion. So this completes the treatment. So medical management first, you need to give morphine sulfate to reduce the pain, and you need to reduce the blood pressure. The target blood pressure should be around 100 to 120 and the heart rate should be around 60 to 70, for which you can give labetalol. And the alternative drug that you can give is esmolol. And then followed by that, diazoxide and hydralazine should never be given. And surgical treatment, urgent surgical intervention is required for all type A dissections. The procedure involves grafting and replacing the diseased portion of the arch and brachiocephalic vessels. And for type B dissection with malperfusion, even they also require an urgent surgery, right? And the immediate goal of the surgical therapy is to restore the flow to the ischemic tissue. Whereas type B dissection without malperfusion, for them, the blood pressure control is the primary treatment. Long-term aortic specific survival and late aneurysm formation rates, they are improved with early thoracic stent graft repair. That will be type B dissection without malperfusion. So finally, if you take the summary of aortic dissection, it is the clinical scenario where there is a sudden tearing type of chest pain with radiation to the back, abdomen or neck in a hypertensive patient. Chest X-ray shows widened mediastinum, right? Pulse discrepancy will be there in both the extremities. Acute aortic regurgitation may develop. So this is about the synopsis or summary of aortic dissection. I'll just show you a clinical scenario. A 50-year-old male patient, an alcoholic and smoker, presents with a 3-hour history of severe retrosternal chest pain and increasing shortness of breath. He started having this pain while eating, which was constant and radiated to the back and interscapular region. He was known hypertensive. On examination, he is having cold, clammy with heart rate of 130 per minute and the blood pressure of 80 by 40 millimeters of mercury. And JVP, it is normal. All the peripheral pulses were present and equal. Breath sounds were decreased at the left lung base and the chest X-ray showed left pleural effusion. What is the most likely diagnosis? Acute aortic dissection, acute myocardial infarction, rupture of the esophagus, acute pulmonary embolism. So this particular patient is suffering with the acute aortic dissection. First and foremost, the character of the pain, right? The pain, it is the central chest pain that is radiating to the back in the interscapular area. That is one point. And the second point is This individual is also having left-sided pleural effusion. That would be the complication of the aortic dissection. And what about the other options? You take acute myocardial infarction. See, the character of the pain of acute myocardial infarction is that it will be retrosternal pain, but that will radiate to the left arm and as well as the shoulder. Whereas you take in case of the rupture of the esophagus. In case of rupture of the esophagus, this will not be the clinical presentation. The individual can also have the presence of the hematemesis. And in acute pulmonary embolism, chest pain will not be the most common symptom. In acute pulmonary embolism, sudden onset dyspnea, that will be the symptom in case of acute pulmonary embolism. So that is the reason why the answer to this question is the acute aortic dissection. So with this, I will wind up this very important topic, that is aortic dissection. Thank you very much.